So this talk is going to be about multiple myeloma, which is one of the commoner hematological malignancies that I would be confident that most of you will see more than once during your professional lives. Multiple myeloma actually accounts for 1% of all malignancies, not just hematological malignancies. And at a frequency of 5 per 100,000 per annum, in the Wellington region we're going to be seeing somewhere between 20 and 30 new cases a year. The graph here is actually New Zealand data from the Cancer Registry, and it shows the age distribution of new diagnoses of myeloma. So you can see that it's not a pediatric disease, and the median age for presentation is around 65 years. There are, however, a few cases that are diagnosed very early, and there are rare cases of myeloma being diagnosed even in teenage. So myeloma is a tumour in which there is accumulation of plasma cells. These are abnormal neoplastic plasma cells, and the normal counterpart are the mature B cell antigen producing cells. The plasma cells accumulate in the bone marrow and also in bone, and they usually produce an abnormal antibody-like protein that we refer to as a paraprotein. As with all the hematological malignancies, myeloma is a clonal disease, so the plasma cells are clonal and the paraprotein is also clonal. It's probably worth spending just a little bit of time on paraproteins because this is something that causes a bit of confusion in general everyday clinical practice. So the paraproteins are clonal antibody-like proteins. They're not performing the usual function of antibodies. They're often useless, but occasionally they can actually cause pathology. They can be any class, so they can be IgG, IgA, occasionally IgM, IgD or IgE, and they can be full antibodies or they can just be partial antibodies. And if that's the case, it will either be a kappa or a lambda light chain on its own. What causes confusion in general practice is that we sometimes see raised globulins as a reactive phenomenon, and people often struggle to understand what the difference is between reactive hypergammaglobulinemia, a polyclonal increase in globulins, and the paraprotein, which is a monoclonal band seen on electrophoresis, which represents the clonal immunoglobulin. So if we see polyclonal increase in globulins, that's going to be a reactive change. If we see monoclonal change, that's likely to be a plasma cell proliferation, possibly myeloma. At first sight, myeloma presentations can seem a little bit complex and confusing, but really we can work it out because most of them reflect either an accumulation of plasma cells that is causing a problem, so a lump of plasma cells, or a problem that results from the paraprotein production. So plasma cells accumulating in the bone marrow will cause a suppression of normal hematopoiesis, and it may result in cytopenias. Plasma cells accumulating in the bone actually interact with the stromal cells in the bone marrow to cause secretion of cytokines that cause lysis of bone. So the characteristic feature of plasma cells in bone is lytic lesions. And that can produce a lot of extra calcium, which can then result in hypercalcemia. It's also possible for lumps of plasma cells to be present outside the bone marrow and outside the bone, so soft tissue plasmacytomas, which just means an accumulation of abnormal plasma cells. And this can be responsible for things like spinal cord compression, when you get a plasmacytoma that's pressing on the spinal cord. So the paraproteins can cause a number of problems. They can cause renal failure due to predominantly light chains of accumulating in the renal tubules, although renal failure in myeloma can be caused by many different things. This is one mechanism. Having a very high level, particularly of an IgA paraprotein or rarely IgM paraprotein, can cause hyperviscosity. And occasionally we see problems arising from amyloid deposition. So amyloid is when light chains are deposited in a particular molecular pattern in tissues that interferes with the function of that tissue. And that can be manifest in a number of different ways. Classically, it causes an enlarged tongue or macroglossia, cardiac involvement, peripheral neuropathy, and occasionally adsorption of factor 10, one of the clotting factors, with a characteristic bruising tendency that tends to appear around the eyes. So another concept I'd like to get across about the pathogenesis in myeloma is this condition called MGUS. So MGUS stands for monoclonal gammopathy of undetermined significance. And this is even more common than myeloma. And what we now know is that all cases of myeloma are preceded by MGUS. It doesn't follow that all MGUSs will transform into myeloma, but we do know that all myeloma has been preceded by an MGUS. So what is MGUS? MGUS is really a very scaled down version of myeloma that is not progressive or only really slowly progressive. So there is a low level of plasma cells in the bone marrow. There's a low level of a paraprotein, and there is no end organ damage from the paraprotein. So this slide deals with the common presentations of myeloma. One of which is bone pain due to the accumulation of plasma cells in the solid bone and the lytic lesions that are associated with that. And bone pain is something that's commonly seen in people in the age group that is affected by myeloma, so can easily be overlooked as a presenting feature of the condition. Another common presentation would be with anemia, and anemia is more common than neutropenia or thrombocytopenia in myeloma, and it tends to be a normochromic, normocytic anemia. So anemia with a normal MCV, normal MCH, that's otherwise unexplained. And again, that's not uncommon in this age group and so easily overlooked. It might be that someone has had a liver function test done for another reason and that they come back with a high globulin level, often with a low albumin level as well. And that could be a reactive change to an inflammatory process. But if that's picked up and electrophoresis is done to distinguish between the reactive polyclonal change and the monoclonal change that is indicative of a plasma cell disease, then that might give somebody a clue to look further into whether or not this is multiple myeloma. And finally, the other real common presentation is with renal impairment. And again, renal impairment is something that's often seen in an older population. So all these common presentations are things that can and often are overlooked for quite some time before somebody thinks, could this be myeloma? So just as an illustration, this is an illustrative case. So this is a 68-year-old man who presents with low back pain, and quite a lot of 68-year-old men will present with low back pain. But he's got an anemia. It's got a normal MCV. The rest of the blood count is normal, but there's a comment on the bottom of the blood count referring to what the blood film looks like, and it says rouleau and increased background staining. And that should be a flag that this could be myeloma. It doesn't mean that it is. This could be a reactive change, but it just should raise that flag in people's minds if there's no obvious reactive cause for these changes. So when we say rouleau, what we mean is the red cells are stacked up together in a line, and hopefully you can see that on this picture here. And the increased background staining means that between the cells, the stain is very blue, which means that there's a lot of protein there. And really both of these things are reflections of a high globulin level. So the last slides were dealing with slowly progressive presentations of myeloma. There are a few emergency presentations that I would just like to highlight for you today. We won't go into them in great detail, but I just want to highlight that these can happen and that it's important to be aware of myeloma when you see patients presenting with these conditions. So the first of these is spinal cord compression. So obviously myeloma is not the only cause of spinal cord compression, but it is one. And it's due to either a plasmacytoma, a soft tissue plasmacytoma compressing the spinal cord, or it might be due to vertebral collapse where there's been a lytic lesion and the bone has become so thin that it just squashes and then impinges on the spinal cord. And recognizing that this could be myeloma, possibly because there are other features that would suggest this on the blood count, the high globulin level, the electrophoresis, might mean the difference between your patient getting prompt treatment and recovering from paralysis and not doing so. Another presentation is with hypercalcemia, and that might present with polyuria, polydipsia, dehydration, and these days most people get a calcium checked. And just be aware, this is one of several causes of hypercalcemia, but in the right context, picking up the hypercalcemia and treating the myeloma may make a big difference to your patient. And finally, hyperviscosity, particularly in myelomas that are producing IgA paraproteins, which are bigger antibodies than IgG, and the very rare IgM myelomas, the blood viscosity can be so high that the circulation is slow enough to affect vision and mental processes and can cause thrombotic complications. So we've got a patient that we think might have myeloma. How are we going to diagnose it? And we need to show that there are more than 10% of the nucleated cells within the bone marrow that are clonal plasma cells. We don't necessarily need to have a paraprotein. Most myelomas will have a paraprotein, but it is possible to have a non-secretory myeloma, so just clonal plasma cells in the bone marrow. And it is necessary to show that they are clonal because you can have quite high levels of plasma cells in the bone marrow as a reactive change. The other things that might be helpful are looking for what is referred to as CRAB end organ damage. So CRAB stands for hypercalcemia, renal failure, anemia, and bone changes. And those are the characteristic end organ features of myeloma. But we don't need that to make the diagnosis. If we can show that there is a clonal population of plasma cells at more than 10% within the bone marrow, that's enough to make the diagnosis. And we can demonstrate clonality with flow cytometry or with genetic or molecular techniques. So this slide just repeats what the CRAB criteria are, and this is one of the things that distinguishes myeloma from the pre-myeloma condition, MGUS. So this slide shows you what we see when we have a look at the bone marrow. The top three pictures are different bone marrows, all showing increased plasma cells. So these are the cells with the nucleus at one side of the cell, with blue cytoplasm and a pale area just outside the nucleus, which is sometimes referred to as a paranuclear HOF, and that's where the Golgi apparatus is. And that's a very characteristic appearance of plasma cells. Probably at this stage in your career, all the white cells just look like blue blobs, but after a while, as a hematologist, these are perhaps the most easily recognizable cells. We can't tell just by looking at them whether they're malignant or reactive, so we do have to do other tests. The bottom picture is there just to show you what amyloid looks like when we see it in the bone marrow. And this is a bone marrow trephine, so it's like a little core of bone that's been sliced and stained. And the pink amorphous stuff is what amyloid looks like under a standard bone marrow stain. If we stain it with Congo red and look at it under polarized light, it will look green. So we call this red-green birefringence when it's stained with Congo red, and that's the characteristic histological feature of amyloid. And amyloid can be a feature of myeloma, more commonly perhaps than is appreciated. If we look hard for it, it can be present in maybe 10 or 15% of cases. Most of the time it won't be producing symptoms, but some of the time it will. And again, it's things like big tongue, heart problems, other organ failures, sometimes skin lesions, peripheral neuropathy, and occasionally easy bruising due to factor 10 adsorption. This is a slide just to give you an example of what we see on plain X-rays when we're looking for myeloma lytic lesions. And this is a humerus that looks really moth-eaten because there are multiple lytic lesions all the way down the humerus. And not only that, there is a pathological fracture through some of the lytic lesions. And again, that's a characteristic feature of advanced myeloma. And it doesn't take much to cause the fracture in this kind of bone. It could be just reaching backwards to pick up a cup of coffee. That has caused fractures in people with this kind of infiltration. We can also do CT scanning and MRI scanning, and we will pick up more lytic lesions that way. As with many of the hematological malignancies, it's general practice to gather some information that will give us a clue as to how the condition is going to progress for this individual patient, some prognostic information. And at the current time, the things that we look for are some serum factors and some bone marrow factors. So the serum factors that are helpful are the beta-2 microglobulin, which I think I've said before is the HLA class 1 protein that is shed by many tumour cells. A low albumin is a reflection of a poor prognosis, and a high LDH, lactate dehydrogenase, presumably also released by tumour cells, is a poor prognostic sign. We also routinely do cytogenetics and FISH for myeloma-specific changes, and that also gives us some information on how the condition is likely to progress, and sometimes it gives us information on how best to treat the patient. I don't think you need to know the specific mutations unless you're particularly interested, but I think it is important to know that cytogenetic and FISH information is prognostic for this condition. Okay, so what can a patient with myeloma expect in terms of survival? It's not curable. Even though we get better and better treatments all the time, we're still not able to eliminate this condition. If we had no treatment at all, the median survival would be about 6 months. But with modern treatments, with poor prognosis patients, it's likely to be about 3.5 years as a median figure. But with good treatments, it will be more than 7 years survival. And some people are living 10 or 15 years with myeloma now, which is a huge advance over the last decade or two. So in summary, multiple myeloma is a common hematological malignancy affecting predominantly an older age group. Presents with complications of plasma cell accumulation and paraprotein secretion, and is something that can be easily overlooked in the early stages. It requires a bone marrow for diagnosis, so you won't be expected to make this diagnosis alone. It is something that is amenable to treatment, although not yet curable. So please be alert to the possibility of multiple myeloma presenting when you are practicing doctors, and thank you for your attention.